Welcome, everyone. Today, we are fortunate that we have two leading experts in the area of overactive bladder. We have Dr. Nuzhat Farooqi, consultant assistant professor at Aga University, who's going to talk about the role of beta-3 agonist. And we have Professor Aziz Abdullah from Liaquat National Hospital, who's going to talk about surgical management. So we know typically overactive bladder patients are treated as a first line using anticholinergic agents. However, the second line agents in patients who do not tolerate anticholinergics is beta-3 agonist. And those who fail to respond to medical treatment ultimately require some surgical intervention. So to talk on those two issues, we have Dr. Nuzhat Farooqi, who's going to take up the role of beta-3 agonist, and I think that's an exciting area. There is now good quality research available on this subject. So over to you, Nuzhat, and you can share your screen now.
Right. Thank you so much, Dr. Hamad, for giving me the opportunity to talk about this important aspect. And I would like to share the. So is my screen visible to everyone?
Yes, it is. Please proceed.
Okay. So basically the title is Indication and Effectiveness of Beta-3 Agonist in Overactive Bladder. And I'm not going to go into the definition of overactive bladder, but we all know that it affects the holistically all facets of life in terms of quality, sexual function, mental health, and sleep. And it has quite a significant economic impact in Western world. In Asian countries, we do not know the exact economic impact we have, but in Western world, it's in billions. So one should know, okay, how much impact it has overall. We know the diagnosis. It entails with any other medical problem, the history, physical examination. You need to rule out UTIs, and not all patients require urodynamics for the diagnosis. The first line management usually entails behavioral and lifestyle modification and patient education. Then comes the pharmacotherapy in terms of antimuscarinics or beta-3 agonist or their combination. And then we have intradestructure botulinum injections or tibial nerve stimulation or sacral neuromodulation. Now, the factors which we all need to consider for pharmacotherapy entails some of the factors which are related to drugs, and some of the factors are related to patients. The drug-related factors include efficacy, tolerability, adverse effects, and cost. And the patient-related factors include patient desire, symptoms, severity and quality of life, their age, their comorbidities, their polypharmacy, BMI, and adherence to these medical treatment. Now, the beta-3 agonist status in the current OAB management guidelines, we all know that pharmacological therapy is second line, and then all these medications have two fundamental voiding functions which are targeted. One is through parasympathetic muscarinic stimulation in voiding phase, and the other one is sympathetic adrenergic inhibition of detrusor during storage phase. Antimuscarinic acts through M3 receptors, and beta-3 basically binds to the beta-3 adrenergic receptors and then mediate through detrusor muscle relaxation, through the activation of adenyl cyclase and subsequent rise in CMP, which leads to activation of potassium channels and direct inhibition of acetylcholine release. This is just to show you a diagrammatic representation where these two functions act separately through different receptors. And there are three beta-3 receptors. Majority is beta-3. This is B1, B2, beta-3, and then it leads to relaxation of these muscles. What is the status? So American Urological Association, the Canadian and European have updated their guidelines recently to include both these drug categories for the second line pharmacological treatment of OAB, along with their combination, specifically antimuscarinics and mirabegron only. There are two compounds which is clinically available, mirabegron and bibegron, and the third one is going through phase 2 RCT, is still ongoing. Coming down to mirabegron, it is basically approved initially in Japan and then United States in 2012. This drug is basically formulated as oral controlled absorption system OCAS tablets, where it has a specific, no fluctuations and a stable release in the plasma, and hence the drug is available. This medication is available in two dosages, 50 milligram and 25 milligram. It can be taken with or without food. Approximately Cmax is 3.5 hours. It is bioavailability absolute is 29% at the dose of 25 milligram to 35% at a dose of 50. It is metabolized through multiple pathways. Half-life is 50 hours, and it is excreted mainly in urine as well as in feces. What is the rationale? Basically, there are two types of contraction in the human bladder. Voiding and spontaneous involuntary contractions during the bladder filling. And all these studies have shown that the MIRA background only, affects the, it has no negative effect on the voiding contraction. Therefore, it has no risk of urinary retention. So all those patients whom we do not have the PVRs, we can easily start with beta agonists, beta-3 agonists. So mirabegron as monotherapy, we will be looking into efficacy, tolerability, and side effects. So there are multiple randomized controlled trials up till now, which have proven that it significantly improves the OAB symptoms compared to placebo. So all the endpoints in any study, including the daily urinary frequency, incontinence, voided volume per micturition, and urgency episodes, have an improvement in all these parameters. So since this drug was approved in 2012, there are multiple studies comparing mirabegron versus placebo. And Victor Nitti and Ian Chappell have reviewed all these studies, and based on multiple RCTs, they done on thousands of patients, it was found that mirabegron was superior to placebo with a statistically significant decrease in mean daily incontinence episode and all the other endpoints which are observed in these studies. So this study done by Keller, it's a remarkable study, as it proves that the tolerability and efficacy of mirabegron comparing to antimuscarinics as monotherapy or in combination. They reviewed and they published that it could be given in combination, and it's relatively safer. The other study also looked into the safety and efficacy of mirabegron. It's a large integrated clinical trial database of these patients, which they reviewed, and they found that mirabegron had significant positive impact on all the parameters of overactive bladder. This is just to give you, I'm sorry for this busy slide, but this is basically the studies done from 2014 till 2020. They had placebo compared to solifenacin, tolterodine, as well as mirabegron in 50 to 25 milligram tablets. And all of these studies have outcome reporting as it is safe, and it has good efficacy and measuring all these endpoints. And all of these studies have reported that mirabegron has good safety profile. So the long-term efficacy of mirabegron monotherapy has been validated after multiple trials, and there's another study called as BELIEVE study, which concluded that patients receiving mirabegron reportedly clinically have meaningful improvement in their quality of life, specifically patients who are elderly. So overall, the literature indicates that mirabegron as a monotherapy offers a clear and a durable benefit in the management of POAB symptoms over placebo, and shows a comparable efficacy to most routinely prescribed antimuscarinic agents. Coming down to tolerability, given its completely different side mechanism of action, it was expected that it may have different set of side effects. Long-term safety data of mirabegron does not demonstrate any clinically significant effects on the cardiovascular system in terms of heart rate as well as blood pressure. So when we compared mirabegron with placebo, it only caused xerostomia, constipation, blood vision, hypertension in a very small percentage of patients in doses of 100 to 200 milligrams. So usually we do not prescribe mirabegron in 100 to 200 milligrams. It is only 25 to 50 milligram which is prescribed and does not lead to any significant hypertension. So there was no differences compared to antimuscarinics in terms of UTI and tachycardia as well. Then when we combine mirabegron with antimuscarinic agents, It has shown superiority in improving the key OAB symptoms. There was a trial called as Symphony trial, and I'll be talking about all these trials in a bit more detail. Then Synergy came. It was a RCT phase 3, and it was done in 42 countries, and it has more than 3,000 patients. Then there was another study which had the extension of Synergy trial. That also showed the positive impact of mirabagrone if you combine it with solifenacin. So this is Symphony trial. It had basically combination of mirabagrone and solifen in patients of OAB. And basically they concluded that all these combinations were well tolerated with no important additional safety findings compared to monotherapy or placebo. This is the Synergy trial, which was the largest trial done in 44 countries. And it also concluded that if you combine solifenacin with mirabagrone 25 milligram and 50 milligram, they both had consistent improvements in the efficacy compared with the respective monotherapies across most of the outcome parameters. Then the BESIDE study, I'm sorry, I'm bombarding you with all these studies, but it is important for us to understand that a lot of important trials have been done and all have been reporting almost the similar results. So this study was also done in 2,000 plus patients, which was basically comparing solifenacin 5 to 10 milligram and in combination of mirabagrone with 25 and increasing up to 50 milligram for 4 weeks. Now, total duration of the treatment was 12 weeks. So overall, the combination of mirabagrone with antimuscarinic provides additional benefit in terms of efficacy for OAB treatment. And this combination was seen to be well tolerated as patient reported outcomes, including quality of life and OABQ symptom bother score were found to be superior in combination therapy compared to antimuscarinic monotherapy alone. Then if you have to combine this with alpha blockers, people have studied again this combination and appear that it is safe and beneficial in the treatment of patients who have lower tract symptoms secondary to BPH and OAB. There were multiple RCTs, mostly I looked into 3, which had lower tract symptoms as well as OAB symptoms, and the combination versus placebo, and they showed positive impact on all of these patients. So the authors concluded that combination of tamsulosin with mirabagrone was equally safe and more efficacious than tamsulosin alone in men with lower tract symptoms related to OAB and BPH. Then combining it with phosphodiesterase inhibitors. Basically, phosphodiesterase inhibitors are traditionally used to treat ED. They were found to be beneficial in treating LUTs in patients with BPH. And there was a study from Japan who studied tadalafil and mirabagrone, and they found that if you use in combination, it has beneficial effect, which is superior to all these medications alone. Then a question comes, who would benefit more from mirabagrone compared to antimuscarinics? Are men going to benefit more versus women? So there are no gender-based differences in efficacy endpoints in multiple studies. Then if the patients are a higher risk of anticholinergic agents, then of course, mirabagrone has a favorable option to treat OAB in patients who have high risk of adverse effects of anticholinergics. In elderly, again, there are studies which have proved that it has overall more safety and tolerability as compared to anticholinergics. And in obesity and cardiovascular disease patients, the efficacy was reported to be similar, but we need more studies to focus on these 2 diseases. Just coming down to a few more studies, there is a study in which they basically looked into the cardiovascular safety profile in refractory incontinent patients with OAB with mirabagrone compared to solifen, and they concluded that the comparable frequency of cardiovascular related side effects, changes in vital signs and ECG parameters indicate that there was no synergistic effect on cardiovascular safety outcomes than mirabagrone and solifen were combined together. Another study which looked into the urodynamic efficacy and safety of mirabagrone add-on treatment and tamsulosin in Japanese population. Again, they had the similar results. Another study in which they basically reported that absence of clinically relevant cardiovascular interaction upon add-on of mirabagrone or tamsulosin together. Again, they had no significant side effect or safety concerns. Coming down to the other salt, which is available with us, Vibagron, and it's a more potent beta-3 adrenergic agonist as compared to the mirabegron, and the potency is about 9,000 times more. It does not inhibit hepatic route. So FDA has basically approved once daily dose of 75 milligram for the patients of OAB. There are studies which have looked into the short and long-term efficacy of Vibagron monotherapy, and they have shown that it is significant in improvement in all the endpoints. In a phase 3 RCT in Japan, they also compared patients treated with once daily Vibagron 50 to 100 milligram versus placebo, and again, a positive impact was observed, which was significantly superior to placebo. Then another study, Empower, which was the first international RCT to assess Vibagron efficacy in about 1,500 patients. And it was compared with 75 milligram to placebo or tolterodine. And they also proved, that the Vibagron was more efficacious as compared to the other. This is just to summarize all these studies, which definitely shows that Vibagron was more efficacious. If it has more efficacy as compared to the other available medications. So they concluded that Vibagron was superior to placebo for the reduction of both the endpoints, and extension of 52 weeks showed that 61% of the patients receiving Vibagron demonstrated more than 75% of reduction in urge urinary incontinence, and 41% of these patients had 100% reduction. That means they were completely dry. Coming down to tolerability of Vibagron, basically it is the same pharmacological family, so it is expected to display the similar side effects. According to the current data, Vibagron appears to be more safer and better tolerated as compared to antimuscarinic, and has minimal cardiovascular side effects, even at a rate of even if they were studied for 1 year. So another international phase 2 RCT, which was done in 1,300 plus patients, they also looked into the reported side effect as dryness of mouth as compared to tolterodine monotherapy or in combination, and they reported that it was better tolerated as compared to the other combinations. In elderly, Vibagron has so far shown to be well tolerated in elderly population. In a subgroup of Empower study, they reported that in OAB patients who are more than 65 years of age, Vibagron efficacy was maintained at 12 weeks for both primary endpoints. And together, based on the good efficacy and safety profiles obtained from the few available RCTs, Vibagron could be an agent of choice for different OAB patient populations, particularly to improve their incontinence. Last study, efficacy of Vibagron and mirabegron for OAB. This is a systematic literature review and indirect treatment comparison. And these are the studies which have compared mirabegron in various strengths, as well as Vibagron comparing to tolterodine and placebo. And all of these studies have basically, they have patients ranging from various age groups, men and women. And they basically reported that mean daily total incontinence episodes at 4 and 12 weeks, all 4 of these medications have the similar response as 52 weeks. Vibagron has significantly greater reduction than the tolterodine. At 12 weeks, Vibagron showed significantly greater reduction in total incontinence episode than tolterodine. Coming down to mean daily micturations, again, at 4 weeks, all 4 treatment options, except for mirabegron, had significantly greater reduction from baseline than placebo. All these treatment had significantly greater reduction versus placebo at 12 weeks. And at 52 weeks, neither Vibagron nor mirabegron was significantly different than tolterodine at 52 weeks, if we look into daily micturations. Then volume voided per micturation, at 4 weeks, only Vibagron and mirabegron had significantly greater improvement from baseline. At 4 weeks, Vibagron showed significantly greater improvement in volume voided versus tolterodine. At 12 weeks, Vibagron showed significantly greater improvement in volume voided. At 52 weeks, Vibagron showed significantly greater improvement versus mirabegron 50 milligram. So in conclusion, beta-3 adrenergic agonists offer an alternative mechanism of action and have increasingly been used in the treatment of OAB to the detriment of antimuscarinics. Multiple RCTs have found mirabagrone to be superior to placebo and to be equivalent to most antimuscarinics in the management of OAB symptoms, with the added benefit of a more favorable adverse effect profile and cost effectiveness. This is first-line pharmacological treatment of OAB with beta-3 agonist is supported by the similar efficacy when used in pharmacotherapy naive patients and in patients previously treated with antimuscarinics. Vibagrone is a new beta-3 adrenergic agonist proven to be superior to placebo, but more studies are needed to assess its performance compared to mirabagrone and antimuscarinics. Further in-depth analysis are needed to evaluate comparative safety, and additional research is needed to determine whether improved efficacy in clinical trials translates into improved treatment persistence in real-world setting. And thank you so much for listening.
Okay, thank you, Nuzhat. I think comprehensively covered the current literature. I think there's some queries from a pretty clinical perspective, and that is that what are the patients in whom one should consider mirabagrone as a first-line treatment?
So I think the elderly patients and in whom we do not know the post-void residual volume, because it does not have retention of urine as a main problem, which can happen with anticholinergics. So I think these are the two patients whom first line could be a beta-3 agonist.
In elderly, there's an issue with hypertension, and we know that hypertension, baseline hypertension increase after use of mirabagrone is a pretty established thing. So,
literature which I saw, they have reported that if you use in doses of 100 milligram to 200 milligram, then there is a risk of higher blood pressure. But if you use in 25 milligram or 50 milligram, the incidence of raised blood pressure is really, really minimal. So I think 25 milligram tablet is well tolerated, and at least I haven't seen any patients reporting their antihypertensive is not working for them.
What are the medications that you would like to avoid? So interaction of mirabagrone, which, as you have said, that the vibagrone have fewer interactions. So what one should be careful about when prescribing mirabagrone to patients who are on multiple other medications?
So patients who have liver problems, one should try to avoid mirabagrone in such kind of patients, and one has to reduce the dose in patients who have liver diseases as well as renal problems. So these are the two kind of patients in which one should avoid mirabagrone.
Right. There's a question about mirabagrone being better than sulfasalazine. So obviously there are studies indicating non-inferiority of mirabagrone over sulfasalazine, and obviously with the different side effect profile, particularly related to the anticholinergic effects. So you think that in elderly patients, you would prefer mirabagrone over sulfasalazine if sulfasalazine has not been used? And the second, is there a gender difference? So do you think that women are better candidates for mirabagrone or men, or there is no difference?
There is no difference. As I said in the literature, in my presentation also, who would benefit more. So there is no gender difference as such. And in elderly and in those patients whom we know that the antimuscarinic side effects would be more detrimental for them, then it's mirabagrone would be the first choice. There is another question.
Zehra is asking about use of mirabagrone in pediatric population.
Unfortunately, I did not come across any study which was favoring for pediatric age group. I think up till now, it's only oxybutynin which is being approved in children. The rest of the antimuscarinics as well as beta-3 agonist, I'm not aware of any literature which is supporting the use of these medications in children.
Thank you very much, Nuzhat, for a very wonderful presentation. And you have, I think, comprehensively addressed the issues related to MIRA background, its mechanism of action, and the clinical study supporting its use. So thank you very much. We now move on to the next talk of this evening, and I'm really grateful to Professor Aziz Abdullah to talk about the surgical management options of in cases of overactive bladder. Thank you very much, Nuzhat and Professor Abdullah.
Assalamu alaikum. I'm going to talk about surgical management of refractory OAB. I think we already comprehensively covered other form of treatment. Basically, it covers both the OAB often causes poor bladder control, resulting in complications such as increased risk of falling, fractures in elderly, depression, social isolation, skin infections. Underlying etiology of OAB comprises both neurogenic and non-neurogenic disorders of function, and hence it has a somewhat broad spectrum of etiology to treat. Pharmacotherapy is the mainstay, as Nuzhat has already discussed in detail. ICI states that first line for refractory OAB, the definition is that when the first line approach is not fully satisfactory or fails after 8 to 12 weeks. Alternative therapy includes a surgical management option, then they should be considered. Main principle of surgical intervention in patient with refractory OAB is to utilize the procedure with potential to achieve a reduction in bladder pressure, induce stabilization of overactivity, and increases bladder capacity. I think the current intervention available to us is intradetrusor botulinum toxin, BTXA, sacral nerve modulation. In more severe cases, when both above mentioned intervention fails, may require undergo bladder reconstructive surgery such as unidiversion, augmentation cystoplasty, and detrusor myomectomy. These are the last option in any surgical armamentarium. Botulinum toxin is a potent natural neurotoxin. I think it was first estimated in 1897, and it describes the side effect of flaccid paralysis. It inhibits the release of acetylcholine at presynaptic cholinergic junction, hence inducing muscle relaxation. Toxin is derived from gram-positive focus Clostridium botulinum. Several distinct structural serotypes have been isolated, and for urologists to use it is type A, which is commonly used for management of patient OAB. When it is injected into the muscle, it is transmitted via endocytosis and bound via synaptic vesicle membrane protein to trigger the exophytic process of membrane depolarization and calcium influx. In unit bladder, the presynaptic cholinergic junction induces detrusor muscle relaxation by inhibiting release of acetylcholine from presynaptic nerve terminal. Hence, it effective when the patient received BTXA, it affected the receptors at detrusor muscle, which cannot be stimulated, and detrusor voluntary contraction are reduced or suppressed. In 1999, it was used first time or described in first time use for neurogenic overactive bladder. It's a simple procedure using a flexible cystoscope, using a cystoscope and a flexible needle that can be done under local or general anesthesia. Dose injected varies from 100 to 300 unit in single sitting and is generally injected into 10 to 40 sites within the detrusor muscles. You can plan it. Site of injection can be interdetrusor or subutilial. It works both. Main thing is to mix. You mix it and make into a 30 ml solution. So each ml contain a wide amount, and you map the bladder out and inject into the detrusor muscle using a needle via cystoscope. You inject all over the bladder while sparing trigon. As you can see, very easy and a simple procedure to do, to inject into the bladder about a distance of 1 centimeter, covering nearly whole of the bladder with around 30 injections, 1 ml of solution. And usually leave the catheter in for 24 hours. Adverse event. A systemic effect is rarely observed in low unit tract injection of BTA. Theoretical concerns are there because of the paralytic mechanism. Possible side effects include generalized weakness, dysphagia, diplopia, and blurred vision. Most common side effects after treatment are pain at the injection site, procedure-related urinary tract infection around 2 to 32%, mild hematuria because of the repeated injections, an increase in post-void residual volume and potentially resulting in urinary retention, or de novo may require intermittent self-catheterization in few patients, around 6 to, depending upon the dose, maybe from 6 to 88%. Sorry, it's a busy slide, but if you look at the above two studies, there a lot of work has been done, which shows a significant effect and improvement varying from between 30 to 60%, and that tend to achieve making patient dry and decreases the frequency of maturation. But there's a patient need to be consulted regarding intermittent self-catheterization. Regarding sacral neuromodulation, in 1940 and 41, these studied a bladder contraction followed by activation of pelvic nerve. In 1960, they were showed Cummins experiment with spinal cord stimulation, and they showed the effectiveness of dorsal surface of stimulating dorsal surface of spinal marrow in acute and chronic studies. it's noted that the surface stimulation at the level of S2 resulted in a generation of high intravesical pressure, although no avoiding was noted. Bladder stimulation and emptying can only be achieved when bipolar electrode are placed in central gray matter of S1 and S2. In 1972, it was reported that use of sacral stimulation in 4 patients and in subsequent review of 27 neuroprostheses used over 10 years, the success rate was around 55%. Since then, sacral neuromodulation is being used quite effectively and is being now recommended as a safe and effective minimally invasive urological surgical technique for treatment of a diverse spectrum of lower urinary tract diagnosis, including refractory OAB. Additional uses of SNM in urology include disorders such as urinary urge incontinence, dysfunctional voiding, idiopathic urinary retention. In clinical practice, all patients being evaluated for SNM would have to be previously received a number of conservative treatment options for the overactive bladder, including anticholinergic, pelvic floor exercises, behavioral therapies, or Botox injection also. Normally, SNM procedure involves 2-phase approach. In first phase, patient undergoes short period of neuromodulation to assess the impact of electrical stimulation on lower urinary tract symptoms. In this phase, the electrode are placed at S2 or S3 sacral foramen, and they are coupled to the external pulse generator under local or general anesthesia. Responding patient of more than 50% of symptomatic benefit then proceed to second phase with placement of permanent neuroprosthesis, usually under general or local anesthesia, like putting a pacemaker around on the side of the iliac crest. These patients requires careful perioperative counseling, and selection criteria need to be very meticulous because in order to express the sensitivity to the patient expectation, I think need to dampen their too much expectation from the patient, and which remains critical to successful outcome for this procedure. I think looking at the analysis of the randomized controlled trials, overall failure rate is around 21% with median follow-up of 18 months. Common side effect for the pain is the pain at the implant site, sometimes leading to migration and leg pain. Other side effects include leg stimulation, disturbed bowel habit, urinary retention, skin irritation at the implant site. Current recommendation in UK and NICE guideline mention up to 2/3 of patients achieve continence or substantial improvement in their symptoms after sacral modulation. And the data also shows the beneficial effect persists for up to 3 to 5 years after implantation. I think 1/3 of the patient may require reoperation because of the pain at the implantation site, infection, or adjustment or modification of lead system. Also, it's been shown that in 1 in 10 patients may require removal of these electrodes, and these patients require a lifetime follow-up. These are some of the studies which show the improvement they have been done. As you can see, follow-up around 12 to 24 months, up to nearly around 3 years follow-up. Failure rate on the removal rate is around, it varies from anything from 2% to 33%. And complications with mainly include pain and lead migration and migration, and is basically related to the implantation of the device. While outcome around it again varies from anything from 56 to 90%. Again, is very much dependent on the selection of the patient, how they are behaving. If you use a strict narrow criteria, most of the time those patients do very well. In conclusion, SNM is a unique and fully reversible treatment option for the patient with the refractory OAB. This technique can be used effectively in patients with urinary incontinence, urinary retention, also used in fecal incontinence and pelvic floor dysfunction. Indicate that 70% of the patient shows good results with the SNL. Bladder reconstructive surgery. The main principle for any reconstructive bladder surgery for refractory OAB involve enhancement of functional bladder capacity and reduction in spontaneous increment of intravesical pressure. Augmentation cystoplasty and detrusor myomectomy are the two of the bladder reconstruction procedures used, which is often performed for the patient with refractory OAB with potentials to achieve this above aim. These are major surgical undertaking, and usually also we add Mitrofanov procedure with it to make a catheterizable stoma for these patients, because invariably they may end up on clean intermittent self-catheterization over a period of time, depending upon their bladder condition. Augmentation cystoplasty, bladder capacity is increased by biovalving bladder wall and replacing with a segment of bowel. Incorporation of bowel segment has a potential of diminishing detrusor contractibility. In practice, ileum is commonly used segment. However, there's no randomized controlled trial comparing augmentation cystoplasty with other procedures, because this is done as a last resort. Results, early symptomatic outcomes are good, around 83% of the patient. Mean symptom score improvement is there. Significant increase in total bladder capacity has been achieved. Around 75% of the patient required clean intermittent self-catheterization. Though on urodynamic analysis, around 31% of the patient had some degree of detrusor overactivity. There's a significant improvement of quality of life score in these all domains. Late complication includes incisional hernia, anastomotic perforation, stone formation, and urethral stricture. Long-term outcome are good in the patient with neurogenic bladder dysfunction, and good and moderate around 58% of patients. In conclusion, overactive bladder affect millions of people worldwide with increase in symptom prevalence with advancing population. Conventional therapy include behavioral modification, use of anticholinergic and beta agonists. In some patient, symptom complex might pursue a protracted course and with potential of severely affecting overall quality of life in these patients. Management of these patients tend to be very challenging, and sometimes you feel that you may end up, you want to refer this patient somewhere else. With the more invasive, minimally invasive procedure over recent years like Botox and S&M, these have encouraging effect in patient with refractory OAB. And the experience with this procedure, Botox has helped quite a lot in our practice, but unfortunately, S&M is not available in Pakistan because of the cost. It can be made available, but unfortunately, the cost is around between 20 and 30 lakhs just for the device and implantation, which is very difficult for these patients to incur. Thank you very much. Thanks, Ahmad, for giving me opportunity to present today.
Thank you very much, Dr. Aziz Abdullah. I think you have comprehensively covered the subject. Any questions from the audience, please write in the chat box or post your or raise your hand and we'll open up your mic. So, I mean, in the meantime, well, our audience are thinking in terms of asking a question. What is your personal preference in terms of doing an augmentation versus detrusor? Is there a cutoff in the bladder capacity? Because I think detrusor myomectomy is something which is described but not very commonly used.
I think mostly prefer doing augmentation. Then again, if you got a reasonable bladder capacity, but on urodynamics, you got a very high pressure. Those are the patients may benefit from detrusor myomectomy. Most of the time, if you feel that capacity is small, then detrusor myomectomy may not help, and you may they may be better off doing a augmentation cystoplasty.
Right. One of the problems that we sometimes face, Dr. Aziz, is that these patients have deranged renal function. It's because of long-term overactive bladder or high bladder pressures. So they develop CKD, and this is one of the contraindication for use of intestinal segment, particularly ileum.
Yeah.
So what are your options in that situation? Obviously, with a creatinine of over 2 or reduced GFR, intestinal segment would be avoided. So what are the options then?
I think Botox will be the first choice. I think the main aim is to reduce the detrusor pressure. I think need to repeat, I think around 3 to 4 months injection and follow them closely. That's one of the reasons. Others can do a detrusor myomectomy. But again, you have to be guided by what sort of intravesical pressure the patient is creating.
Right. So I don't see any further question. Yeah, so I would thank Dr. Nuzhat Farooqi, Dr. Aziz Abdullah for their very insightful presentations on this important area, which is significant clinical value, because these are the patients that you do see in your practice on a daily basis. So with this, I would like to announce the next conceptual based course, which will be on 18th of June. And our speaker is going to be Dr. Tariq Al-Shaiji. He has special interest in female urology, urogynecology, reconstruction, and functional urology. He is the consultant urologist and elite urologist at the Amiri Hospital in Kuwait. The session will be moderated by myself and Dr. Mehwish Nadeem, and most of you do know Mehwish very well. Mevish is at Southeast in Leeds. She's a consultant, and she has, after her training, she did a fellowship in reconstruction and female urology and functional urology. So she will be moderating this session. And in the end, we are going to have a post-test on overactive bladder covering the anticholinergics, the MIRA background, the surgical management, sacral neuromodulation. And I hope that you will benefit from that post-test as well. So with this, thank you very much and good evening, and Khuda Hafiz to all of you.
Allah
Hopefully
Hafiz. Thank you,
on-
Omar. Thank you, everyone.
Thank you.
Thank you so much. Allah Hafiz.